Okay. I guess we'll get started. It's 4:30. Welcome everyone to Chronic Pain Gains in Alberta. This is an ECHO series, and I'm Kathy Scrimshaw. Leah Phillips, who you're used to having as a facilitator, is unable to attend today, so you'll have to bear with me. Our didactic session today will be on cannabinoids and pain, and we're very grateful for our peer colleagues to be here to present that. Next slide. Before we get started, I do want to acknowledge that I'm speaking to you from the traditional territory of the Blackfoot Confederacy, and that as an organization, the Alberta College wants to acknowledge that we call Alberta what we call Alberta is the traditional and ancestral territory of many peoples presently subject to Treaty 6, 7, and 8. And we want to recognize also the Métis settlements. I would like to acknowledge and thank the many First Nations, Métis, and Inuit who have lived in and cared for these lands for generations. I make this acknowledgement as an act of reconciliation, and I am very grateful for the friendship and being allowed to work and play and live on their traditional territory. Thank you. And so this is the agenda for our session today. I will do our housekeeping, introducing the team. We'll have a brief 10-minute didactic session on cannabinoids and pain. And then we have a very interesting case from Dr. Tina Hung that we'll be discussing. And then we should be wrapped up by 5:40. Next slide, please. And so today's team is Kathy Scrimshaw, that's me, Salam, and Maya. Our disclosures are that we're paid employees of the Alberta College of Family Physicians. I also am a contracted employee of Alberta Health Services in the Indigenous Wellness Corps. Next slide. I also want to acknowledge that this program receives financial support from Health Canada, the Substance Use and Addiction Program. And we also provide in-kind support from the Alberta College of Family Physicians with administrative, logistical, and technical support. We also want to acknowledge that Jessica Kirkwood and Danielle Perry will receive an honorarium from the Alberta College of Family Physicians for their presentation. Next slide. We do try very hard to mitigate potential bias, and if you recognize or perceive any bias, please let us know. Our material and learning objectives and our session descriptions are developed and reviewed by a planning committee, and our information and recommendations in each session are evidence-based or guideline-based, and sometimes can be opinions of the independent speakers, and we'll identify those as such. Now, the housekeeping, to capture your attendance, we need you to click on the survey link in the chat log to enter your name and email. During the discussion, you can either write your questions in the chat or use the raise hand feature on Zoom, and I think everyone knows how to do that. We'll have a dedicated time for Q&A at the end of Danielle and Jessica's presentation. And during the case presentation, there's lots of opportunity to ask questions and post comments. Valuation at the end is super valuable for us because we want to hear from you and how we can improve these sessions and whether they're serving your need. So how to echo, turn the cameras on if you can. We know bandwidth can be a problem. Please make sure you're on mute, and we just want to try to create a compassionate and kind space where we can all discuss complex cases and support each other and learn from each other. Next slide. And we've already introduced the support team and our ECHO Hub team today. We have Kelly, Julie. I don't know if Ted has joined us yet. Yeah. And Amy and Sasha. These interdisciplinary team members will provide support throughout the ECHO presentation. You can learn lots more in the bios that we'll post in the chat. Now, with no further ado, I'd like to introduce two colleagues I've worked with in the past. And so Danielle Perry is a member of the peer team. She is an RN from the University of Prince Edward Island, and she has a master's in clinical epidemiology from the University of Alberta. She's been a peer team member for 5 years. And for those of you who don't know peer, it's a group of primary care professionals who develop and present practical evidence-based content free from pharmaceutical influence for primary care. They are the authors of the tools for practice that come into your inbox almost every week. Danielle is working as a correctional nurse at an Edmonton institution. She experiments in the kitchen. I'm not sure what that means. She may share that. And she travels back east for a beach in her family. Jessica Kirkwood is our next speaker, and probably needs no introduction to this group either. She joined peer in September of 2019. She's an assistant professor at the University of Alberta. She's been a family physician at the Boyle-Macaulay Health Centre since 2012, and she provides primary care to patients that are unhoused and experience mental illness and substance use disorder. She is a passionate educator, and I've had the opportunity to learn a lot from her about caring for marginalized patients in a way that's empathetic as well as evidence-based. She attended medical school and residency at the U of A, has 2 kids, a fluffy dog, and a very patient partner, as we all do. So I will turn it over to you, Jess and Danielle. I don't know who's speaking first.
Thank you so much, Kathy. That was great. All right, we'll get into it. We're used to giving tight presentations. This one's extra tight. So we're going to go through some of the evidence behind medical cannabis and what we found when we looked at our own guideline looking at medical cannabis for a number of things. And then Jess is going to give us some practical tips as well. So if we just want to advance the slide ahead. All right, so is it high time for medical cannabis? That is the real question. It's been legalized now for 4 years, so I feel like this is a blast from my past, but I love talking about this. I think it's fascinating, so we'll get right into it. Just quickly, my disclosures. So I'm actually paid by the College of Family Physicians of Canada. I'm a full-time employee there, and like Kathy mentioned, I work part-time doing some correctional nursing for CSC. And I also receive honoraria from a number of nonprofits, including ACFP, CEP, and Dalhousie, but I never take any money from industry. You can advance.
Yeah, and pretty similarly, though, not as exciting. I only take speakers honoraria from the Canadian College and the Alberta College. And Danielle, do you take money for your kitchen experiments, or is that just
I would love
pro
to.
bono?
If someone wants to give me some money for that, I would take it.
That's
not industry.
Yeah, but otherwise, no, I'm paid for by the U of A, and then I do my clinical work out of the Boyle-Macaulay Health Centre.
All right, so let's jump into some. Okay, so I already talked about the objectives. I'm going to start with a bit about the evidence, and then Jess is going to come in with some of the practical stuff. All right, so a lot going on in this slide, but I'm going to jump right in and bring you back to 2018 when the peer team basically undertook a systematic review to inform a national guideline looking at medical cannabinoids, which was the first of its time. We traveled all over the country talking about this, and Jess has gracefully just popped that in at the right time, the guidelines, so you guys can access it. And my focus today is going to be going through some of the evidence around chronic pain. So in this big table, if you see the first 5 lines, these are essentially the numbers from 5 systematic reviews that encompass the majority of evidence looking at chronic pain. So when we started looking at this, we were looking for any definition of chronic pain. However, when you actually dig into the evidence, all of it is either in chronic neuropathic pain, so our fibromyalgia, diabetic neuropathies, or some palliative chronic pain. So dealing with patients with cancer, they're more palliative, treating them at end of life. So I think if you just advance forward, I wanted to draw your attention to, and just one more. this second, just one, there we go. So this second systematic review. So you'll see this yellow column on the right-hand side. This is our numbers needed to treat. You might have seen this number before. It's essentially the number that you would have to treat for one patient to benefit. In this case, for one patient to have a meaningful improvement in their chronic pain. This second systematic review, their NNT looks a little bit more impressive. It's a number needed to treat of 6 compared to the others that we reviewed. And the reason for that is because this systematic review looked specifically at smoked cannabis. And I just wanted you to remember this for when I go forward and talk a bit more about the biases in these studies and why that looks a little bit better than what we're actually seeing in practice. One more click. So this bottom line summary is where I want to finally draw your attention to. What we did as a group was we essentially compiled all this evidence into our own meta-analysis and found a number needed to treat of about 11. So we would have to treat 11 patients with medical cannabis for one to have a clinically meaningful improvement in their pain. Alternatively, we could say that 39% of patients given cannabis would have a meaningful pain improvement compared to 30% on placebo. So the majority of this evidence is actually in synthetic cannabinoids. So looking at nabiximols, nabilone. So if you want to click ahead, I wanted to focus on the 2 best trials in nabilone, which is our oral agent we have here available in Canada. So remember, these are the 2 best that we could find. The first being a randomized trial in patients with fibromyalgia. We have 40 patients with chronic pain given nabilone or placebo for a grand total of 4 weeks. Not super impressive. Usually when we look at chronic pain literature, we want to see a duration that reflects the nature of the condition. Chronic pain can last for months to years, but unfortunately, much of this literature is in the short duration. So 4 weeks is actually long for some of this evidence. So when they compared the 2, they actually found nabilone was better than placebo. So improved pain by about 15 points out of 100, or about 1.5 out of 10 above placebo. The second trial actually looked at nabilone versus dihydrocodeine. This was in a general population of patients with chronic neuropathic pain. Again, followed them for 3 weeks. And in this case, they looked at the proportion of patients who had a 10-point improvement on a 100-point scale. So having that like 1 point improvement on a 10-point, and actually found that the opioids did better. So 19% achieved that endpoint versus only 5% with nabilone. If you want to click ahead. There are other pain conditions that I haven't talked about. So my focus, of course, where the bulk of the evidence is neuropathic pain and palliative pain. Rheumatologic pain is important. We have tons of patients coming in with low back pain. And actually the peer team just released a guideline looking at chronic pain. Specifically, we had a section on low back pain. Unfortunately for cannabinoids, there's insufficient evidence. There's only one small RCT that we could identify in low back pain, and not enough to create a recommendation. When it comes to acute pain, we wanted to highlight this because it's kind of all over the place. So in the 7 RCTs that looked at acute pain, 1 decreased pain, 1 made it worse, and 5 had no effect whatsoever. And finally, it's important to note that the majority of these studies looked at the outcome of pain. And while that's important and our patients often present with pain, over time, we are thinking of things like, okay, how do they function and move through this pain? Because they're living with it for months and years. So we're concerned about their function and their quality of life. And unfortunately, in this literature, it was either not reported or the quality of life just remained unchanged. So we're not able to comment on those outcomes with this evidence. All right, so 2 main problems with this evidence, and I alluded to this when I said that the smoked looked fantastic, and it's because these issues are permanent, or they're pertinent throughout all of the literature in medical cannabinoids, particularly when it comes to smoked. So the first one is blinding. So if you just click forward, yeah. So blinding is when, if you're enrolled in a study, you shouldn't know what you're getting. You shouldn't know if you're getting the intervention or the control. And even though the medical cannabinoid literature sometimes attempted to blind, it wasn't usually tested. So we wanted to dig a bit further and look at the studies that actually said, okay, we blinded, but did it work? So click forward. This is what was found. So in 2 studies looking at inhaled cannabinoids, the first one, they randomized patients to either 0%, 3%, or 9% THC cigarettes, gave them all in a random order, so blinded them. gave them a break, and then randomized them all again. So they were essentially moving through 6 phases, 0, 3, and 9, in a random order. And when asked, almost 60% were able to identify all 6 phases correctly. It was even more prominent when you look at just cannabis versus placebo cigarettes, 90% were. And this persisted even in the oral agent. So dronabinol is an oral agent not available in Canada. When asked, 95% of patients were able to identify active, as did 85% of the nurses that were caring for these patients. So they were able to look at the patient and say, okay, this patient is high, this patient isn't. So blinding didn't work. So the ones that tested it were able to confirm it just doesn't work with this agent because of the obvious side effect profile of this agent. The second issue is who they actually enrolled in their studies. So previous users of cannabis were often focused on. So when we looked at 6 inhaled studies, 3 required them to have past use, 2 didn't put a limit on it, and 1 didn't report. So why is that important? So if I have tried cannabis in the past and had a horrible reaction, I'm not going to enroll myself in a study looking at medical cannabis. So oftentimes these people have had success with cannabis, they tolerate it well. When we looked at the nausea and vomiting literature, so we looked at treating nausea and vomiting in chemotherapy patients. If you were a previous user, you had a better response. And if you were a naive user, you were more likely to report a more severe adverse event like psychosis. So the problem with focusing on previous users is it excludes that population that are naive to it. So we don't have a great representation of the adverse events associated with these, with medical cannabis. And unfortunately, this permeates throughout and leads to profound bias. And it has affected our recommendations, which Jess is going to go into.
Okay, Danielle, thank you so much. So this may look familiar to you, it may not. As Danielle mentioned, I popped the guideline into the chat, but this would be the algorithm that Peer came up with in our guideline. And we try to stay away from algorithms when we're talking about chronic pain, and we recognize that patients present very independently. And so in our chronic pain guideline, we tried to just offer like a menu of options and enough information to be able to help shared informed decision making. But when we're talking about cannabinoids specifically, I think it really helps to just kind of go through this. So really, if you're considering prescribing cannabinoids, you want to know if it's for any of those main conditions that are listed there. So that would be neuropathic pain, palliative pain, spasticity in MS or spinal cord injury, as well as chemotherapy-induced nausea, vomiting. If it's not, we really don't recommend using it. And this is really consistent actually with the CPSA guidance, as well as this really helpful document that I had all teed up to send in the chat, except I can't find my enter key. There we go. That came out from CFPC in March of 2021, looking at, again, guidance in terms of prescribing cannabis in primary care. It's a 72-page document, so it isn't a 10-minute presentation kind of thing, but it is very, very valuable. And if this is something that you want more information about, it's a really awesome document. So yeah, looking at those main conditions and then moving on, because it isn't just have they not tried anything, we're going to move directly into cannabinoids. We're going to talk about, for neuropathic pain, have they tried 3 or more other options? And for palliative pain, have they tried 2 or more? Or if they've been refractory to standard therapies for those other conditions. Again, if that's a no, we really don't recommend proceeding forward. We think you should stick with things that have a bit better evidence and a bit more evidence of benefit and less harms. But if yes, then moving on. And there's a bit more specifics in terms of, are we looking at nabilone versus nabiximols? And really here, prescribing medicinal marijuana as a first line would absolutely be something that we don't recommend, and that in all cases, potential harms and benefits really need to be discussed. To move on to the next slide. So I promised like a little bit of practical, which is just a total fraud kind of move, because I really don't prescribe a lot of cannabinoids in my practice. And I actually ran around my office and asked a whole bunch of my colleagues as well. And especially with legalization, my patients, if you're not aware, are typically, as Kathy had mentioned, unhoused, on social assistance, or facing severe poverty. And so no one can afford, even if they have a prescription, afford buying some of the products. But I do talk with them a little bit, because I certainly wouldn't be naive to think that people aren't using cannabinoids to help them in some way. The different forms that are available are kind of listed in picture format there, but just so you're aware, when we're talking about nabilone, that is a capsule form, and it's a racemic mixture of THC isomers, whereas nabiximols comes as it's a buccal spray, and it's a plant extract with a combination of THC and CBD, as well as some other cannabinoids, flavonoids, and terpenes. So, oh yeah, I'm trying to advance my slide. Excellent, that's great. Just looking at cost of these products, this isn't an inexpensive option by any stretch. Nabilone is covered by most provincial drug plans, so that is definitely what I have the most experience in prescribing, whereas nabiximols, as you can see, it can be quite expensive, as well as dried marijuana. And so just when we're looking at, you know, how you're wanting to prescribe that, actually, hold on. Nope, that's actually on my next slide. One other thing I was just going to mention, oh, right, just that physiological effects can typically start anywhere between 30 minutes to 4 hours. But when we're talking about some different forms, they may take a little longer. Peak effects usually somewhere between 2 to 4 hours, and duration 6 to 8, but that can last up to 24 hours. And so there are some really strong recommendations in terms of telling patients how to drive or how not to drive, I suppose, if they've taken their medication recently. We'll move to the next slide. And oh, you can just hit that. I think all the words will pop up. You can just, there we go. I think one more. Beautiful. So in driving in particular, really recommending not driving 3 to 4 hours after you've had inhaled medical marijuana. And so that's why I'm talking about that specifically. 6 hours or more if oral cannabinoids have been taken, and then 8 hours if a high was noted by the patient. And really we're trying to strive that a high shouldn't be noted. And so that's where looking at some of these numbers, where prescribing guidelines typically recommend about a maximum of a 9% THC. And so how that prescription can be written if you're prescribing dried cannabis would be 1 gram of dried cannabis with 100 milligrams of THC to kind of specify how you want that ratio. There is specific forms that you have to use to prescribe, again, if you're looking at getting your patient to access cannabinoids through dispensaries, through certain providers. And then the dosing, if you're looking at dried cannabinoids, is like a drag, like an inhalation. And so it obviously isn't super scientific and really specific, but like 1 drag would be about 100 milligrams. And you would start with just once a day. That amount should hopefully not produce a high. And if a patient is saying that they're feeling a high, that's where you need to look at kind of backing things down a bit. And if you have, or if you know of anyone that smokes weed, or you have any patients that smoke weed, you'll know that that is like so far from what is actually happening in real life. It's not even funny. And so that's where I have a lot of patients who have smoked weed their whole lives. They really feel that it helps, but the amount that has been studied and that would be prescribed is astronomically different than what they're actually using in common practice. Because as you can see there in Canada, you can have up to 27% THC, many are around 15, and people can smoke like many joints a day. So when we're talking about 1 drag once a day versus, you know, multiple joints a day, patients can easily have 20 times the recommended dose. And so that's where in my practice, I find that, again, I don't have patients that can afford cannabinoids and dried marijuana products that they buy from a provider. But if I try to put them on nabilone, I don't really have any patients that are like, wow, that nabilone really just changed my life, and they just like skip out of the office. It isn't really a massive change for them. If anything, it would be patients that are more probably cannabis naive, that have tried many different options, that then I would say, let's consider trying nabilone. And sometimes then those patients go, what? I don't want to try weed. So you really can't win either way. Let's move on to the next slide. Basically, I don't even know how we're doing for time, probably went over because that's the story of my life. But bottom line would be that at the very best, when we're talking about chronic pain, we're looking at something that would be meaningful. So a greater than 30% increase, an improvement in pain really only happens for 1 in 11 patients. And that's specifically looking at chronic neuropathic pain versus placebo. Get you to bump ahead. And just as Danielle mentioned, highly biased research, so the effect is likely exaggerated, and it's certainly unclear if one type of medical cannabinoids is better than another. I absolutely do not recommend something that is smoked over something that could be swallowed or eaten, purely for additional lung risk factors and things. So I would absolutely recommend tablets. Or if I was using like a dried marijuana product, then I would probably tell patients to consider the oils, which you actually just write the same prescription and then you specify that they would want it in oils. And that document that I put in the chat has a lot of good information in terms of, there's even a chart looking at the gram volume that you prescribe and how much oil that would actually be for your patient. So yeah, that was kind of that. Non-inhaled forms are recommended. And definitely once others have been trialed, particularly if we're talking about chronic pain more than 3. I think that's us in a nutshell.